So, welcome. Hopefully everyone had a good lunch. As you see, we're shy one person. We had I don't know if it was Maria, but one of our the other presentators had the encounter of COVID showing up in a family. So I don't know if it was her or if she had a conflict. But so part of the reality that we're dealing with. I'm Michael Shea. I'm managing director of strategy consulting and around identity in people, things, and organizations. And I'll be moderating, or really more part of a conversation, I think, with Simon and Steve. And you know what? I will let you each introduce yourselves.
Thanks, Michael. So my name is Simon Wickes. I am director of an NHS primary care organisation. I'm also chief operating officer of True, which is a healthcare digital staff passport startup.
Thanks. My name's Steve Roest. I am the CEO and co-founder of Vital Sign Solutions. We are a sort of health tech, next generation diagnostics business, trying to enabling anyone with a smartphone to give themselves a blood test for a range of conditions that include cardiovascular disease, diabetes. We've also done quite a lot of work in COVID with DHSC as well.
So the last few years, last couple of years, 18 months, 20 months now, I think the whole world of healthcare has been rocked in a way that I don't think anyone could have ever foreseen. The challenges of identity, whether it's around staff allocations or just even access, and whether it's telemedicine or healthcare delivery at home or virtual ward concepts. This is where we're going to talk about today on how the identity elements and what were some of the challenges, or what are some of the challenges, how are they dealing with. I know True, Simon particularly, in some of the staffing challenges that the NHS experienced here in the UK, has been part of. Can you give us a bit of some information on what the challenges were, how some of them are being addressed?
Yes, sure. So the common misconception about the NHS is that it's a one NHS. It doesn't operate like that. NHS operates...
Simon, sorry to interrupt. I think your microphone is off, so they might not be able to hear you on the live stream. If you just flip the switch, does it say?
Is that working?
Is that on now? Yeah, okay. Well, sorry about that.
You're allowed to talk in a minute, don't worry.
Yeah.
Just have to wait, just have to give it a few seconds. Yeah, just...
Yeah.
They realised they booked us by mistake. They're like, wait, you guys don't do fintech? What are you doing here? Get them off. Cut the mics.
Really sorry about that. See if that works.
Let's try that. Is that better?
Is that better? Yeah.
Excellent. Okay. So one of the misconceptions about the NHS is it's one big organisation, and it really isn't. Lots of disparate organisations all under one umbrella that have to follow the same rules and regulations, but they act as different employers for different groups. So whether you're a doctor, a nurse, a physio, whatever your discipline is, you will be employed by that hospital, that primary care organisation, whoever you're working for. And when you move, you've then got to go through the same identity check. So there's a set number of checks that need to be done, and they are done in person. They are paper-based, and it means that doctors, nurses, allied health professionals are taking time off work to move hospitals. And that means wasted time. It's time away from patients, it's time that they're supposed to be taking in rest, and therefore they're losing that time either away from the hospital, and therefore patients aren't getting seen. The NHS did some work, and I think 100,000 clinical days are lost every year just from junior doctor pre-employment checks. So that's 60,000 junior doctors in the UK. That's a huge amount of time that's wasted. So when COVID hit, and obviously the demands started to go through the roof in terms of the hospitals, it wasn't nationally. We've seen it in later, sort of the second and third wave, that it's almost all hospitals that have been hit. But the early stages, it was very, very regionally based, which meant that some hospitals are being hit very hard, other hospitals not. But what we were seeing is a reduction in elective procedures and generally just people going to hospitals. So what that meant was that there was a surplus of workforce in some hospitals and a shortage in others. But the ease of which you can move from one hospital to another is very, very difficult. And what they wanted to do, what the NHS wanted to do, because we've been working with them for several years and demonstrating what digital staff passports could allow, was almost instantaneous movement of staff between hospitals to respond to hotspots and to respond to shortages. So back in March last year, they commissioned a group of organisations, including True, to deliver a digital staff passport purely for COVID, to demonstrate, to be used so they could speed it, but also to demonstrate all the work that we've done previously. So what that meant was that trusts could have the platform. They acted as the issuing party. If we go back to John's diagrams, the issuing party, and also other trust actors, relying party, with the doctor or the clinician in the middle, holding a verifiable credential that allowed them to then swiftly move and be authenticated or checked to go into the new hospital. And that meant then that the workforce was much more fluid, and they could respond to the need. And it wasn't just the UK. I mean, it's the only UK that use it in this way, but there's a paper being published in the US where, with the demand that arose in New York, you had clinicians wanting to come from California to help out, and it was taking 2 weeks for them to move across the country, and obviously not physically, because that's just how long the checks are taking. Now, it's a highly regulated industry. There's a lot of trust in there, and so it's got to be done properly. But things like verifiable credentials and digital staff passports based on self-sovereign identity allows that to happen. And that's what we were able to deliver. So as it currently stands, the COVID digital staff passport's in 100 NHS trusts. And it's being used as well for vaccination centres. So it's allowing the vaccinators to move between vaccination centres as well, by being able to prove that they are suitably qualified, as well as, obviously, there's the identity aspect to it, but there's also the qualification aspect to it. So we're kind of moving past pure identity and moving into all the aspects that are around it that need to be verified, and effectively talking about authentic data, not just about the identity itself.
Okay. So, and we'll come back, I think, to the staff, but I think the other part that is around that Steve's organization, and I guess the context is around the patient, but also is almost the decentralization of delivery of healthcare. That one of the challenges that Simon just touched on is that procedures and services could not be delivered because people couldn't get into the hospitals. Either they were afraid to get in the hospital or told flat out, do not come into the hospital. But yet, health goes on. So how are you, within the context of sort of decentralized healthcare delivery, I think that what you guys are doing covers on that area, right?
Yeah, so we developed a platform, we call our technology platform PocDoc. And PocDoc allows anyone with a smartphone to give themselves a blood test in real time using just the app, and a series of lateral flow tests that we develop in-house in our research labs up in Cambridge. The goal of the whole company is really to increase access to healthcare. So we realized that for certain key diseases, cardiovascular disease, type 2 diabetes, there are a number of others, actually access to blood testing is actually quite difficult and really not very patient-centric. Often involves one or more visits to your healthcare provider, take time out of your day. It's often a venous blood draw. I think we're all kind of familiar with generally what it's like to go and get a blood test, and it's not necessarily the most convenient. With increases in processing power and image analysis, image quality of smartphones, we realized that there was an opportunity to reinvent some of the old lateral flow test technology. So lateral flow tests are traditionally, as we all know, thank you very much, COVID, great for yes/no answers, qualitative, right? Am I pregnant? Am I not pregnant? Do I have COVID? Do I not have COVID? Where they've traditionally been very poor is in providing a quantitative level. So the leap that we've made is to create quantitative lateral flow tests that can be read immediately by the PocDoc system, and the results are available immediately. What does that really mean? Well, It means that there's a big kind of movement within healthcare called the democratization of healthcare, or the reduction in health inequality is something that the NHS is very interested in. So how do you take blood testing out of GP surgeries, out of clinical environments? How do you give people access to their own information so that ultimately for these diseases like cardiovascular disease, like type 2 diabetes, where lifestyle choices make a huge difference to the potential outcome, why wouldn't you want to give people access to that? And so that's the area that we're in, whether it's in a non-clinical setting but still managed by a healthcare provider, so for example in a local religious centre or a community centre or a school, or if it's truly in someone's house and they're testing themselves. All of that is something that we're working on with our tests and the PocDoc app. And I think what we already saw this move to digitization of healthcare pre-pandemic, but the pandemic obviously put some rocket boosters under it. The genie's not going back in the bottle. So really the only way for healthcare systems now to deliver the quality of care at the volume that is required to meet, even come close to meeting the demand at a cost that's acceptable to governments and taxpayers, is to continue on with digitization across all aspects, not just diagnostics. So creating diagnostic solutions that allow at or near patient measurements to be taken, monitoring to be taken, blood testing to be done, that is not something that's going to be decelerating anytime soon. That's going to be accelerating. And it's not just in the UK. So we actually are working with the Gates Foundation and an NGO called Path to do something very similar for polio testing. Obviously, the areas of polio hotspots are not necessarily on high streets in Surrey. They're out in the kind of back and beyond of places like Pakistan, Senegal, Tunisia, and a number of others. Obviously, if you're dealing with those kind of healthcare systems, they don't have a very solid pathology lab structure. You can't get the people that are most at risk to a pathology lab to be tested. So you're, by definition, looking at lateral flow testing in order to hit those economies of scale and that accessibility. However, as we, again, all know from COVID, the lateral flow tests that we have are basically just stupid bits of plastic. So how do you create an app or middleware that can digitize, can be rolled out at low to no cost in those environments, highly robust, very low cost to actually go out and implement, but that can digitize those results to allow those rapid tests to actually be used in population health systems? That's really where what PocDoc is focused on across a number of disease areas. And I think to the point that you were making around accessibility, I think it's slightly tangential. Identity management is a core part now of the acceleration of the digitization of healthcare. Healthcare is being digitized across every single aspect of the healthcare pathway, not just from a clinician side, but also from a patient side. What is not going to happen is that there's going to be 12, 20, 50 different identity management solutions. They're all going to end up getting centralized in some way, shape, or form, particularly in a system like the NHS, particularly at primary care. So to the extent people know this, but 75% of all GP surgeries use one patient management system called EMIS. 75%, right? So what EMIS chooses to do in this space is pretty much going to dictate what happens, across the whole of the UK. So again, yes, there'll be lots of different solutions right now, but then it's going to come right down because there's going to be one sort of, I believe, one or two or a few identity management systems in a business like us. When we roll out our diagnostic component, which is our strength, we'll ultimately integrate via API or some other methodology to be able to verify those informations in real time. There's no reason, or there makes no sense for each health tech company to build its own verification system. I don't believe. I believe in sort of each business working up to their own sort of pay grade on that. So that's sort of my view on the whole thing. Increasing access to digital identity can only help every health tech, including us at PocDoc.
I think one of the challenges in conversations that I've had with different healthcare executives, across from the insurance side to the delivery side to technology providers, is also around having the trust and the trust in the system. Trust is always the big question, and particularly technology companies these days in the healthcare area in particular. Trust is a very tricky question.
Mm-hmm.
What are the challenges getting the confidence that the system, that what's coming off, whether it's staff credentials, like for example, what were the challenges for you guys what were the resistance factors in talking with some folks here in the NHS? There were some real cultural things that people were saying that were becoming big barriers to getting participation.
Yeah, absolutely, and the barriers come from, I guess, multiple sources, multiple parts. And if you go in and talk to the HR departments in the hospitals. They'll talk to you about governance and the fact that they are subject to audits, and therefore, having the physical document is, I've got it in my hand, therefore it's real, and therefore it's, and then when it comes audited, I can hand that over, and that becomes quite important. They become attached to that. There's also the overarching guidance, so the way in which clinicians are onboarded and have their checks done in the UK is governed by NHS employers. They set out six areas, and you might get a hospital that wants to adopt what's the new technology, but unless you can evidence that it aligns with NHS employers and almost get a seal of approval from them that says that yes it does, you're not going to get adopted. So there's governance aspects to it. There's also then the individual aspects to it and the confidence it brings. So if we take that from a clinical workforce perspective, it's the trust of what's been issued to you, that it is what it says it is, and how that can be used, and the fact that it's going to save you time as well, because the last thing you want is a new technology, and we do see it in the NHS, new technology being introduced that's supposed to save time, but it doesn't. It's badly designed, and it's technology for technology's sake. Yeah. This is a problem that needs to be solved, and it just so happens that approaches like we've talked about is an appropriate way to solve it, really not the other way around. From the patient perspective, then, you've got this establishment of trust, and we talk about how do you trust a doctor. When you go into a hospital, how do you trust it as a doctor? Well, they look the right way. They're wearing a badge. They've probably got a stethoscope around. We have this is what a doctor looks like. A nurse might be. And they
might have something hanging on their wall.
Yeah, well, yeah, sometimes. Yeah. If you're having a remote consultation, how do you know that's a doctor? You don't. There's no way to prove it. You're putting your trust in the platform that you're using, that they've gone through the right steps. Well, there are plenty of examples out there where doctors have been practicing fraudulently, and you can't check that. Yeah. So being able to convey that trust then between almost peer-to-peer is going to be important as well. So we see the rise in remote consultations. It went up 80% during COVID. The government's trying to redress the balance. They're trying to inject some money into the NHS to push face-to-face consultations. Actually, patients are saying we don't want that. We like the flexibility.
It turns out I don't want to take half a day off to go and have someone listen to my chat. I mean, it's again, the genie's not going to go back into the bottle on that one. But sorry,
carry on. It's not just here. I mean, I'm here talking with a health insurer in the Netherlands. It's the same thing, and it's not just the young people that are saying it, right? It is the older generations. They're saying, no, I don't want to have to travel 100 miles to get into a hospital to be checked, right?
Absolutely, and then so the ability then to add point of care testing as well is huge. It's hugely relevant, because there's only so much you can do just talking to the doctor, and being able to push on to the next stage to do that through a trusted medium, and that is the important bit. Doctors and nurses are one of the most trusted professions in the world, and whatever therefore gets introduced at an identity level, at a testing level, needs to be consistent with that level of trust that goes across the profession. Otherwise, you're undermining the whole.
And we've also seen recently what happens when you undermine it too.
Yeah, I mean, I would concur, and I think that from our perspective, what we've been hearing from both private and public providers, both here and in other locations, is that there is a desire to continue some percentage of digitization of healthcare. Some people want to do more, some people want to do less. Some people are trying to sort of, force the market back towards more face-to-face things, because that might please some of their, voter base, some may argue. But, fundamentally, digitalization is going to be here to stay, and it's really more around how do you integrate with the right businesses and the right elements to make sure that can be delivered smoothly. So your point around diagnostic testing is a really good one. So you can have a fantastic digital face-to-face consult with somebody. You can organize it within minutes. It can happen. You can have it in 10 minutes, and it's all been fantastic. But if that person then says, "Oh, you need to go and have a blood test," you're straight back into the old analog system. Take time out of your day, go to a testing center, arrange an appointment, wait for the results for a week or two, and so on. And that's something where the interest certainly in what PocDoc is providing is being able to actually, within that consult, order a test that's immediately sent out to you at home. You do the blood test right there and then, the results are available right there and then immediately, and immediately integrated back up with your primary care physician. That's obviously the dream that we're moving towards, because that for them maintains that user experience. So one aspect of this digitization, which, you know, I don't know whether you've come across from an identity perspective, is that, you know, in lots of other areas of our lives, whether we're ordering food or booking a taxi or booking a holiday, the experience that we have, millions and millions of pounds are spent by each company delivering that perfect user experience. There's a huge amount of research that goes into it. Whereas I think in healthcare, that's coming. You know, it's been more focused on the functionality and not necessarily the usability, particularly in the UK. But I don't know whether you have any thoughts about that.
Lots of them, because that's very much the focus of what we're trying to achieve. The days of technology for technology's sake has got to go. It's got to be centred around the user, centred about what they want to achieve, how they want to interact with it, and what they want to achieve. Mm.
So, just to be a little contrarian, and
Please.
particularly about technology, and particularly on startups, there is certain motivating factors and driving factors that sometimes causes questionable behavior, and particularly in the healthcare context, that can cause an immense amount of problems in damaging the trust element. How do you see then, from whether it's as a decentralization of healthcare delivery, whether it's from a staff or a patient side, what are the biggest challenges that you see, or challenges in front of both of you as being parts of startups, not to burn the trust bridge accidentally?
Yeah, I think it's a great question. I mean, in the diagnostic space, we are a medical device developer. You know, people in that space by definition generally are medical device developers. There's certainly people that try and sort of exist around the edge and sort of argue that their thing doesn't qualify as a medical device because of X, Y, and Z. But fundamentally, medical device developer, there's a huge amount of regulatory oversight in that space. CE marking, FDA marking, also from a data protection side of things, or a sort of information security side of things, you've got Cyber Essentials Plus, and you've got, on the NHS side of things, you've got something called the DTAC. So there's quite a large and long and painful regulatory process that you have to go through. So to be a medical device developer, you also have to have something called a ISO 13485, which is a hugely painful quality management system process that effectively controls every single aspect of your entire company, which is very, very valuable in terms of traceability and being able to trace back every single aspect of any product that you ever make. But you will have to do that before you even have a product on the market. Now, what we saw with COVID, which was kind of an interesting loophole, just as a slight aside, is the COVID-19 lateral flow test, the antigen test, were being manufactured in China under something called a self-certification. So they weren't audited, they weren't controlled by anyone, but there is a loophole in the medical device regulation. So they were being able to be imported and relabeled in the UK and then moved on as if they hadn't necessarily been sort of tested and verified, which is sort of what probably where the issue was. And that's partly why I think they had to go through a huge amount of kind of re-evaluation when they got here. And ultimately the government said, yes, in the real world, the accuracy is obviously lower than it is in the clinical lab in China or whenever they did the clinical testing. However, on a cost effectiveness basis, we're okay with 70% specificity, 70% sensitivity, as opposed to 99% because of our ability to scale this testing program. We think it's better than not doing it because we don't have the capacity or the funds to do PCR-based testing. So they kind of made the right decision in the wrong way, arguably. But yes, that's sort of to your point. So I'd say from a medical diagnostics perspective, we can deal with a lot of that reputational issue because we have to go through all of that pain and justify and verify before we can even get a product out there.
Yeah, but you are making the distinction that you're actually a medical device company
Yeah.
versus an app on a...
We have an app. The app is the way that exactly. I mean, but there is nowhere if we were just an app, then we wouldn't be able to give anyone any blood tests. At some point, someone has to pierce their skin with a thing to get some blood onto our tests. So yeah, unfortunately, even our most sophisticated regulatory people weren't able to jiu-jitsu our way around that one. Yeah. So I don't know if you want to.
Well, so we're not a medical device. We look at it classifies that. So first of all, True was founded by 2 NHS doctors, and they are passionate about solving the problem for them and their colleagues, and therefore it needs to operate in the right way because it needs to establish the trust of the whole healthcare workforce. What we do, though, and the way the digital staff passport works is it's not the company that's providing the verification. We're not providing, we're not asserting anything. We are providing the conduit for trust to be established between organisations and putting the individual at the centre of that. So we are not checking someone's passport or driving licence or medical degree. It is the existing organisations that currently do it to a set standard that make the check. They then issue a verifiable credential to the doctor, and the doctor holds it in their wallet. When that needs to be verified, that's requested from the relying organisation, and it is that version that is shared with them that's cryptographically signed and immutable and all the good things that self-sovereign identity creates. All we do is provide the conduit for that to happen. The other beneficial thing as well, the whole kind of ecosystem here is, we're talking about decentralised identity here. You can't have decentralised identity with one organisation providing all the infrastructure, because that's just not decentralised. Our position is to encourage competition in this arena, because the more companies that are doing it, the faster things will happen, but also it allows choice, and as long as we're interoperable, which is what we all want to achieve, then there's no single reliance on any given organisation to be able to provide provide it to a standard that they want to. It's got to provide it to the industry standard. And I'm sure over time, because this is so new, regulation will come in. There'll be no reason not to. But the other thing they need to be careful on is that we're not just talking about the NHS here. And if you talk to a doctor, they are not owned by the NHS, even if they work for them, because they do private work. They'll do remote consultations. They'll do lots of other things. And so whatever is put in place needs to be interoperable outside of the NHS as well as inside the NHS.
We were speaking to a virtual GP company. It's quite large in the UK, and they were saying a lot of the time what their vision is to try and to have a 24-hour service. And so, when the doctors in the UK aren't online, they would like to be using doctors on a different time frame, a different time zone, rather. So, it's not just within the UK, it's also if there can be some kind of international standard of some sort, then that would allow freedom of movement of work across borders, effectively, virtually and digitally, which I think would be extremely interesting in terms of that would even out supply and demand. Probably have a whole bunch of unintended consequences, but that's the nature of things. But it'd be kind of interesting to see. I don't know what you think.
Medicines without borders.
Right.
Perfect.
So, in just to dig a little bit further on the staff passport. So if I've understood you correctly, a doctor's at a particular trust. That trust goes through the cost, bears the cost and the diligence of checking that initial set of pieces of paper and whatever, creates a digital credential, which then can be reused at any of the other trusts that haven't done, as long as they're accepting the digital credential. Is that correct?
It is to an extent. So we have a problem in the sense that there are 300,000 doctors already practicing. Yeah. So you've got a legacy issue, and then we've got medical students coming through. So for the 300,000 existing doctors, that's exactly how it works. So they would go through the usual check they usually do, because that's a cost that's already incurred by the hospital. As they're doing the existing physical check, they would then issue their credentials, and not in one big credential, lots of smaller ones. And then when they need to be onboarded at another hospital, they make that request. With the new medical students, as we start building this up, it will actually, so that will be secondary credentials where it's being checked by the trust, because they're not the ones that did it in the first place. Where new students are coming through, there'll be primary credentials, so it'll be credentials issued by the university.
Okay, that was exactly where I was going.
Yeah, by the DVLA and those sorts of places. So and there will be a distinction, but obviously they'll be identifiable as well. So when you, as a relying organisation, when you receive the credential, you can see who issued it in the first place, and that's quite important, because you're not going to accept a medical license from the local Tesco's, but you are going to accept it from another NHS trust or from the GMC. So it's important to be able to differentiate between those and establish the trust framework as to who can issue certain types of credentials, and who would trust them.
I think it's important that we're not talking about here outsourcing the verification, right? The verification is still being done by the same organizations that always verified. It's just a significant upgrade in the system.
I think a slight difference here, and maybe more compared to other industries, particularly in the context of the NHS and the NHS Trust, they're not necessarily in competition with each other. Whereas in other industry segments, that someone who creates a credential for whatever may object to their direct competitor using that credential. So in this case, there's at least an incentive or a motivator within the ecosystem as a whole for a degree of cooperation.
Yes, there is, but if you extend how the ecosystem will operate 3-5 years' time, we're going to talk micropayments here.
Yeah.
And I can issue, as an organisation, I can issue a credential to you, and every time that you share and it's read, and by relying organisation, I get a payment. So yes, it might be you might be sharing with my competitor, but I'm benefiting because I'm actually taking money from my competitor, because the money's coming from the relying organisation, not from the individual.
Okay.
Yeah, I think that raises some interesting. I'd be interested to see how that flows out in employment law. But yeah, I think there's going to be some freedom of movement issues there probably. But I think it's super interesting.
So how, from an identity of the patient right now, with what you guys are doing, how do you?
Our main focus is on being, as we spoke about before, is being as interoperable as possible.
Yeah.
You know, we're not looking to pick a winner in terms of a verification service. So whatever the current existing best standard is that's used at the NHS or any of our private partners, we ultimately will do that. And there is a range. You know, for example, you know, on the one end there's DHSC who's doing it a particular way, and then there's private people that already have, I guess, they already have accounts. A lot of these people, particularly like digital wellness partners, they already have a user account. So that's a already existing form of verification that they've sort of created themselves. So, and then there's obviously primary care that's doing it a particular way. Our goal is just to be able to integrate and do it however that person wants us to do it. That's our view. So
the person does a blood test at home, or does some sort of a lateral flow test at home.
They open the app.
You have to use the traditional Alice. Alice does her test. She wants to send it to Bob. And Bob is somewhere within an integrated care system. How does it get there?
Sure. So the core functionality is that the person pricks their, Alice or Bob, whoever, pricks their finger, puts a very small drop of blood onto a lateral flow test, and then there's a series of reactions that take place based on a color spectrum. So the more intense the color, the higher the concentration of whatever we happen to be measuring. The diagnostic step within the app is that you open the app, and there's a highly adaptable health questionnaire that we can ask around the condition. So cardiovascular disease, we ask a lot of questions that allow us to calculate BMI, alcohol usage, smoking status, previous history, that allow us to flow that through into a risk assessment at the end. Then there's a step where the user has to take a photo of the test after 5 minutes. That photo is then sent up to our cloud, where we analyze and convert those colors into the concentration through a series of AI algorithms. And then the result is returned to the device in question, whether it's a phone or a tablet, so the person can read the result right there and then, or it can be or it can be integrated immediately and shared back up with wherever it needs to be shared based on Alice or Bob's personal preferences or healthcare provider preferences. So for example, in the case if it's an NHS primary care relationship, they would want that result, the NHS and primary care would want that result immediately shared back. So one of the big issues in terms of taking diagnostics out of surgery is not even just with the actual biochemistry, measuring the result, is actually what you do with those results. So if it's happening out of surgery, people are writing stuff down by hand. Those are being collected and then taken off somewhere, and then they're going to be written up, and that creates a whole bunch of GDPR-related issues because that's extremely sensitive data as well as manpower. So being able for that information, that test result, to be immediately shared back immediately is a massive upgrade on what's currently happening. So we've got the capability of effectively shipping out individual tests based on individual orders that could happen in real time. We have an API integration with our manufacturing partner that's UK-based, medtech specialist. So from a practical perspective, Alice's physician could press a button, order a test, and that would then be API shared with us, which we would then share with a manufacturing partner. It would be picked, packed, and sent out the same day. So that's how it might work. I mean, there's lots of different variations on that, but fundamentally that way, if it was for an individual. If it was more in a community setting and it was more for a screening effort, then we obviously would have larger packages of things done and keep those supplied. But yeah, the idea is to be as flexible as we possibly can and really be led by the healthcare organizations who are trying to solve these issues. We're not trying to kind of tell people that they should need to be tested when they don't be. We're talking about improving access to testing where there's a desperate need for it, and obviously a stated aim. So with cardiovascular disease, it's the single biggest killer in the UK. Type 2 diabetes is one of the, if not the largest cost centre for the NHS. So there are huge goals that every primary care trust has about addressing these issues, and there's a huge lack of solutions in the diagnostic space, cost-effective solutions.
Good. Any questions from Big Brandy?
Thanks. So one of the problems with digital identity in healthcare, especially systems like mine in Canada or yours in Britain, is that your consumer is the entire population, which means that every edge case is one that you're going to have to deal with. As in the private sector, you can fire customers that are too difficult or too, or whatever. But so one of the examples that I've had to deal with, especially if you've got an interoperable health record, is physicians who are seeking medical services that could impact their relations in their home clinic. And the traditional way is they go to another clinic and deal with their issue, whether it's a sexually transmitted disease or a psychiatric issue or something that they think may impede their relations at work. But now that goes into an interoperable health record because there's a single identity and everybody in the health system has records to it. Or has access to it. And there's other edge cases, but how do you sort of square the circle of a necessarily single identity that links to a patient and an interoperable health record, because I think that's where you started this, and having some amount of patient privacy in that context.
So the way, I mean, at the moment there is not a single interoperable health record across the NHS. But the way in which the patient care records work are that not everything is can be readable, can be viewed. It can't be requested. So effectively, there's an opt-out that says I don't want this information to be read by anyone else apart from my GP or the doctor, and that exists, as I said, at this point in time. So whether if you come in for psychiatric cases, if there's a safeguarding issue within families and things like that, all that information will get uploaded to your record, but effectively there's tick boxes. I mean, that raises questions about usability and tick boxes, but yeah. we'll skim over that one. And who makes the decision? But that already exists. So and when we're talking about single identity, what we're talking about is being able to gain access to systems, not necessarily, we might want individuals to hold all their information in the future. I don't think we're anywhere near it at this point in time. But what we're talking about is how you gain access, the authentication through a single identity that's not owned by Amazon or Google or Facebook or whoever else you're using to log into the different platforms, and putting it the responsibility of the individual, and that can be we can talk passwordless single sign-on with QR codes and and verifiable credentials if you want to go that way, but that's how it's currently done, and if you move to the position where the individual holds all their records and then shares it, then it's up to the individual. It's selective disclosure then of saying this is what I want to share, this is not what I want to share. But then that then raises some other medical questions to do with I'm going to give you an incomplete set of my records as my doctor.
Well, and data security and the liability of that's. I think just to come in on that point slightly tangentially, one of our partners is a major diagnostics company called BioSure. They're the leader in HIV self-testing. And over the pandemic, they effectively shut all of the sexual health clinics in the UK, which is kind of a problem if you wanted to get tested. Obviously, in theory, there shouldn't have been that much, social contact with people that you don't already know. But there's some things happen outside of what the rules are. And so they actually saw this huge increase in the need for their products being self-tested at home. And for people to take that responsibility of self-testing themselves at home. When you test yourself at home, you don't you're not offered the choice about whether, or, well, right now you're not, about whether it would go into your health record or not, right? It's a personal, private choice of you've paid £10 to have a HIV test sent to your house, and you've tested yourself, which I think is sort of a little bit like what you're saying, which is that if I choose to have a test done or done somewhere else myself that I don't want to be part of my core record, then how do I facilitate that? And in an instance where you can go to a clinic that's a walk-up clinic, then obviously you don't need to register. You can give whatever name you want. You don't even need to give your NHS number. But yeah, if that doesn't exist anymore and that gets shut, well then those people are going to try and seek those tests somewhere else.
Well, I'm somewhat reassured. I have to do my day 2 lateral test in a couple of hours. So.
Okay. Well, that's a different ballpark to HIV, but good luck with that.
So, to touch on, there were some conversations in some of the panels earlier in the morning about a single identity. Is a single identity a good thing?
I think it all depends what you mean by single identity. I mean, if what we're talking about is putting the identity in the hands of the individual, then yeah, absolutely. I mean, that's what happens in the real world. You know, you hold all your documentation and you choose who gets to see what.
But if it's the metaverse?
It depends what Mark Zuckerberg's got view on it, really. But I mean, I think the whole thing with the metaverse is again very interesting, because Facebook are responding to the problems they've had with privacy and the problems we have with data sharing. You know, we're hoping that it's going to put all the data back in the hands of the individual, because that's where it should be. That's what happens in the physical world. You know, the internet was not set up as to create trust between, certainly for individuals, and an identity, and therefore we need to be moving on to Web3, where that can be established and allows you to be in control of your own data, and that's what we're talking about. I mean, we're talking about single identity, but it's literally empowering the individual.
So the key part is the single identity that's actually controlled by the individual, not necessarily from an operational efficiency of a single identity in the NHS, that the NHS has all.
Yeah. I mean, a single identity in the NHS won't work on the basis, because there's so many different systems. There are so many different trusts. They're all set up differently. They've got all different clinical systems. They said there is no one NHS, and therefore you can't then expect that to promulgate across the whole of the NHS. And then you flip that over to the fact that doctors work in private as well as NHS. Why would you just not empower them with something that they can use across all the different use cases that they face, rather than saying, well, if you're the NHS, you've got to do this, but if you're in private industry, you've got to do that. And if you go to the US, you've got to do something completely different.
50 different states.
Yeah. We were talking to the Federation of State Medical Boards on this, so yes, I mean, again, even within the states, as you point out, 50 different states, 50 different ways of doing it. You know, so give the individual the power to be able to respond to what's needed, rather than necessarily expecting everyone to fall in line saying we only do it this one way.
Yeah, my point would be really more around choice. You know, I think that anything that increases someone's ability to choose their healthcare options and choose what information is shared, that I'm all for. Any kind of, and that's why we set PocDoc up, was to allow people to choose to opt in to be tested, or choose to get access to their biological data, instead of having to always go to the doctor and have that managed for them. So that sort of democratization. So anything that really goes down that pathway, then I think we would wholeheartedly support. I think on a personal kind of basis, this idea that some single identity is going to be forced upon us, and suddenly you're going to have all your data and you have to sort of manage all of that. I find that maybe it'll happen. I don't necessarily think that's going to be for everybody. I think there'll be some people I think that there's a reason why some data is held within organizations, because you can put in place, or in theory, you can put in place protections and systems and processes to sort of manage that. Whereas if you were to sort of give everyone their entire medical file, and every time they had to show up somewhere, they had to make sure that they'd got access to it so it could be scanned. I don't know, that might be a little bit of a stretch, but anything that allows people to choose their healthcare and have more access to healthcare, if that is via some kind of image verification system or whatever, identity verification, then bring it on.
Okay. Laura, are there any questions online, or anything online, or any? Is there?
There wasn't.
Okay.
We're almost out of I
That's
hate
fine.
to stop you. I feel like it's a topic you could talk about for hours more, but we did covered a lot of ground there, I think, even touching on the metaverse at the end there, so I didn't think we'd squeeze that one into this session, but it was fantastic. So thank you very much, Steve, Michael, Simon.
Thank you.